Well, it's a real honor to present to this group, especially the hardcore here that have stayed the whole day. And I'm really grateful to ASSEP and NIDA and CDC for bringing us all together. It's just a pretext so that we can, learn from each other today. And I really felt this was a stimulating day. I'd like to just thank my collaborators, from not only the people that are in this room that have taught me so much, but the people at my Department of Emergency Medicine, Project ASSERT, the BNI ART Institute, and our collaborators and funders from the state of Massachusetts, Bureau of Substance Abuse Services, and giving me this opportunity to share with you our experience in Massachusetts. We were able to bring our passion to improve the care of patients with unhealthy alcohol and drug use through a grant from SAMSHA in 1993 for critical populations of vulnerable, underserved people. And this was Project ASSERT, and ASSERT stands for basically improving substance abuse services and education and referral to treatment for our patients. And there were two major streams that came together to bring this idea to being in 1993. One was the work of community health workers, health educators or peers throughout the nation for underserved populations. And the other was what Chris was describing, was the science and research and clinical practice of motivational interviewing, especially the spirit of motivational interviewing developed by Miller Rolnick. And I was really fortunate to have their mentorship in developing Project ASSERT in 1994. Dr. Rolnick came to Boston, and Gail D'Onofrio was in the audience, as well as some really people that have contributed to the field, like Richard Sates. And he basically shared with us the spirit of motivational interviewing and helped us to bring it into a brief algorithm called the BNI that you've heard all about from Dr. D'Onofrio and others. And I feel that more than just this algorithm or script, they contributed to many of us to improve our communication style, our ability to respect and be more compassionate and actually listen to our patients and collaborate with them in some sort of plan to improve their lives. So I think that's more than just any particular formula. It's really the spirit that they brought in, the research and rigor. So what happened then was that we recruited people from the community to do in-reach, people that had networks of resources that cared about the problem. We brought them into the emergency department and helped develop and foster a new workforce called health promotion advocates, or in Spanish, promotores de salud. And for the last 20 years, they've consulted and trained providers throughout the country and within our own institution. And for the patients, they've helped motivate them and steer them in the right direction through not only navigation, but also helping them to go to places that they never thought they could go. And they go, this workforce of around 7 people work from 9 in the morning to 12 at night, 7 days a week in our ED. And in a typical year, and this is last year's data, around 5,000 patients were seen. And the way they were seen is that the physicians and nurses would call Project ASSERT to the bedside. They have an office right next to the emergency department, and they would have this conversation based on motivational interviewing skills and also the resources to try to see what people need. And 1,500 of them were actually placed through active referral process and detox. And that's not a small thing in our state, because we've seen many cutbacks in services, and as Chris said, it's nice to talk about getting people into treatment, but they actually utilize the marginal capacity of the treatment system, find a bed, build the relationships with the different providers, and make sure people get there. So they help them through the intake process, they provide transportation, they negotiate with the insurance companies, and sometimes walk them across the street through a tunnel to the detox across the way. They also are involved in finding primary care appointments and behavioral health appointments. And in the last few years, they've been spearheading an initiative in our state, because we've seen a lot of opiate overdose deaths, to do opiate education and naloxone distribution to our patients. I think it's one of the first actual programs in the emergency department. And last week, the Medical Executive Committee of our hospital passed a standard and policy that all people coming through the emergency department with an overdose have a right to be educated in naloxone and overdose, and given the naloxone if they want it. So the whole plan is that they don't leave the emergency department without this, if possible. Project ASSERT is part of the medical, as part of the team, but they also document in the medical record a standardized, validated screening, the results of a screening, validated screening instrument. They do a comprehensive health and safety survey of the patients in terms of whether they have primary care, insurance, they smoke, they feel threatened, and then they also address these issues of substance abuse. They use the BNI and document the action plan of the clients, and then they refer to treatment. And all this becomes part of the record, and it's also part of adding to and upgrading what they call the E&M codes, the evaluation management codes, so that we can bill for these services. Knox Todd is here in the audience, and when we presented in the 90s this project was ready, he said, well, where's your randomized trial? So we were able to get funded by NIDA to have a randomized trial to test this model of peers, and we were able to show, using hair analysis from baseline to 6 months, that we could increase abstinence and reduce use. The leadership in Massachusetts is quite fortunate. We had Michael Botticelli, who is now the Deputy Director of ONDCP, which is the Office of National Drug Policy, as our leader. And he put into our state policy a commitment to SBIRT as a strategy. And so we worked together to implement this in Massachusetts, and he provided our institute with funding so that we could translate our knowledge into practice. And we used key constructs of implementation science to do this, and I think I'll just read this, starting with evidence-based practice, establish common goals and funding. I think you all know this. Create a partnership with communities and networks. This is critical. Adapt to local conditions and enhance the ownership and autonomy of the local folks. Maintain your fidelity and have a process of collecting data and using this data to improve the programs. But no matter how you think about this, it's not a straight line or an easy deal, because they have unintended consequences. We talked about at this meeting when you try to apply guidelines or decision rules, or you find unintended consequences, like we talked about increase in heroin use. But we have limited control when we implement these things in people's providers' behavior and the institutions, as well as we're at the mercy of the political and economic system, as the shutdown has shown us. In order to evaluate the program, we use the REAIM framework, which stands for Reach, Effectiveness, Adoption, and Implementation, and Maintenance. We pulled together a consortium of stakeholders that represented our state's organizations of ASSERT, ENA, Hospital Association, consumers, and treatment folks. They issued an RFA to the state, and they marketed this RSA to their organizations. And 19 proposals were reviewed by this committee, and then 7 were selected for each region of our public health region of our state. The state gave us $50,000 per health promotion advocate to give to each of these sites that were selected. We signed memorandums of agreement with each hospital, and they agreed to send their leadership team from the emergency department to the institute for training. And then through the training and planning process, they set up these meetings at their own institution for training their own staff and beginning to hire and implement the program in their local settings. And the institute provided technical assistance and ongoing supervision and monitoring through site visits and listening in on the conversations they had with the patient and monthly telephone calls. So we really can't just throw people out into the wind after training. You have to really be with them. You have to be with their institutions and provide some structure, planned sustainability from the very beginning of any program. One of the biggest tensions, though, I think we should face is that SBIRT really is a public health approach. And that means that it's population-based. It's for the universal screening. Well, the emergency department isn't like that. It's about the flow and acute care of patients. And so there's always a tension between these two things, and whether you can spend your time with the most acute, or you have to step out of that role and just keep screening people. And so the more people screen, the less time you can spend with each individual patient who has more acute problems. So this has always been a tension within this. There was certainly tensions in introducing a new workforce. So just giving you an idea of what our reach was, 33% of the people we screened positive for unhealthy alcohol and drug use using some of the same instruments that Gail presented. But what's interesting here is that 69% received referral to treatment, specialized treatment. That tells us something. One, we learned from our data that there's a high rate of cocaine and heroin use, and particularly prescription drug use in this population. And that's greater than some of the studies that have been released so far, including the SBIRT SMART study and the SAMSHA studies. That rate is much higher, and so is the rate of referrals. 69% referral to treatment is a pretty high rate coming out from an emergency department. So and I think that's because our emphasis wasn't on marijuana, and most of these studies are on marijuana. So, but you can see the array of referrals to Suboxone, methadone, holding as well. We saw a lot of variability in treatment, and I think that's important to look at over the 6 years of the grant. So there's a big dip because the state went through a recession, and they said we have to cut your funding, and they cut a third of our grant, and we had to go back to the sites, and we lost some sites, and at least 5 health promotion advocates out of the 12. There's also variability and turnover within the staff, so that that definitely compromises your ability to reach your goals. But the more you screen, is the more it gives you an opportunity, the more you have a chance to intervene. There's also variability within the different sites. The last two sites, 6 and 7, have their own psych units in which they do all the referrals and negotiate the problems with treatment, so that you can see there was less of the green or the referrals in those sites. And other sites, they try to balance out the two, this tension. And I think the tension was to make sure that we do as much screening as possible and give people who would be the hidden population a chance to get a screening. This isn't a study right now, study data, but it's just part of the protocol, which was to call people at 30 days and check in with them and see if they've been carrying out their action plan and see how successful they were and see if they needed anything. But in the emergency department, it's hard to locate people, and you had to have their permission to call them. So, but I think we do have some indication here, at least that people did get some benefit from the program, at least those people that were contacted. So where are we on June 30th, 2013, when the grant ended? So we had 6 of the 7 sites have continued. I think our goal from the very beginning, our objective of what we intended to do is sustainability and maintenance. So we did sustain this program in the majority of sites. But these sites weren't the sites that didn't sustain the program in the exact way in which we had thought at the beginning. So these are the unintended consequences or unintended results. But I think they liked, some of the sites liked the social work model and wanted people to be able to bill for the services with a license. So they basically hired social workers to fill this position from health promotion advocates. So that was very interesting development. The other thing is that as a result of having this study, this grant in our state, other health systems have contacted us for technical assistance and training. So under the grant, we were able to pay for the particular salary lines, but in this new environment, we've been able to do more outreach into health systems. And recently, we were contacted by another health system that are hiring behavioral health navigators, because this is a hot idea in the present ACA to have navigators, because people don't know how to get through this system. And we've been asked to do the training for this group. Just looking at some comments from in interviews in one of our papers is patients don't fall through the cracks, and we're beginning to focus on treatment and support rather than just stabilizing and sending patients on their way with a list. I guess we thought about our culture as treat and street. And I think because we had the trainings for the staff, we integrated a new role or new workforce, people began to see that there's other possibilities for the emergency department. One of our leaders in an outlying hospital said he didn't think this was going to work because it was going to interfere with flow. But he basically he's one of the people that have kept this program and have used this program to influence the rest of his network, because he thought the operation would come to a halt without the health promotion advocates. So what do we learn from this, not so clean, implementation process? Well, I think I would say there are 3 major things. One, you can't, even though external funding is important, you can't change things from outside. You basically have to have inside champions, inside the sense of autonomy and ownership within the institutions you work with. They have to own it and want to fight for it, and you have to be able to adapt to their needs, and they can change it, and they should change it so it meets their system. The second is that we have to adapt to, we're still victims of bigger forces. And so we expected that the state would turn on the Medicaid codes for screening and brief intervention, and that we would have an economic base for this program. And our state resisted it. I think there are only about 15 states in the country that have turned on these codes, and that was the CMMS codes. So we really didn't show the sites that they could support this. We tried to work with them from the beginning around the evaluation and management codes, but they were sort of reluctant to start billing the system while they had a grant. So we struggled with that. So now they're on their own. And actually during the cutbacks, some of the sites had to take on some of the lines themselves. So they did show some good faith in that. So I think I'd like to at least have a few minutes for questions, because...
If it's okay, we'll do questions
yeah.
at the end of everybody's presentation. Is that okay?
Right, yeah.
But you have 1 more minute.
Okay.
Yeah, go for it.
So I think I want to talk a little bit about some models. And some places are starting to implement this. If we have an electronic medical record system at triage or for our nurses who can do the screening, and a brief screening, of course, then that can trigger these health promotion advocates through an electronic system and their board in their office to come to the bedside. And so we can make sure, through the data set, we can make sure that everybody gets this. In Atlanta, I think in the Grady grant, they started to do this and they found some success. But I think that's the possibility, because I don't think we can spend so much money on screening and have so little time and money for the resource of the brief interventions that we have. So that's really critical. If you look at Dr. D'Onofrio's study, only 2.8% screened positive for her study. So that's a huge number of people that were screened, but they didn't get to that level of getting an intervention. And finally, there are other measures, there are other ways of sustaining this, and I think they're coming forward because with this whole idea of pay for performance, that there are quality incentives coming off the board for different types of practices. So if we could work politically to make SBIRT or some of the screening thing and intervention things part of quality performances, we have a chance to get reimbursed or at a higher level. And finally, for the staff, to keep them engaged, they have to see some benefits in flow and patient satisfaction. And one of the reasons why we have Project ASSERT there for the last 20 years, and it was a time when they wanted to drop it, was because the nursing staff came forward and said that they didn't want to work without it. So I think we need approaches in the emergency department that engage nurses, social workers, physicians, and this extra designated hitter. But last night I was quite disappointed with our designated hitter from Boston, because we really didn't. So whatever Chris says about these two things, the designated hitter or the team players, I think we need both. And sometimes you're not going to win even no matter what you do. Thank you very much.